Mualik Josie, welcome to the podcast. And, for contributing a terrific case study to the Health Equity Case Studies Handbook. I have certainly learned a lot from you in the last couple of years. Let's start off with something about your background, how you came to Meritus Health, and something about the organization. It's a big, complex organization. Tell us more about yourself. Tell us more about the organization itself.
Peter, thank you so much, and I appreciate your time and the opportunity to chat. So thank you. So I have been at Meritus now for over 6 years, starting on year seven. I most recently came from Anne Arundel Medical Center, where I was a chief operating officer and executive vice president, and I have some very fortunate ability to interact in lots of organizations. I worked at the American Hospital Association for
Right.
almost 8 years and the Institute for Healthcare Improvement. And so I think all those have been able to shape and influence my abilities to try to contribute to health and healthcare. Meritus, I love. We are an independent, not-for-profit, regional academic health system. So although we're not as big as some of the large academic health systems, we still do a lot of the same things. And we have a level 3 trauma medical center, Meritus Medical Center, 327 beds. We have a 65-bed psychiatric hospital, Brooklyn. And last year, we launched the Meritus School of Osteopathic Medicine, the
Right.
first new medical school in Maryland in over 130 years.
How did that come about?
Yeah, so I was chatting with our team and just threw out an idea, October 11th, 2021. Hey, how about a medical school? And the
Sure.
reason being, physician shortage is profound in
Yeah.
many areas, especially in areas like us, a little more rural, underserved, and other areas as well. And we don't have the pipeline in place to address this anytime soon. So we thought, why not go all the way upstream and invest? And we're not going to make money on this. We're going to lose money, but it's the right way to invest in a community and a region for the future. And so we said, let's do it. And we invested a little over $250 million. And in
Wow.
3.7 years from that, we had our first class start last July and now on path. Our second class will start this July, just in a few months, 135 slots. And we already have 2,700 applications for that 135 slots.
Is it your hope that the graduates of the program, assuming you go through the internship and specialty training, that they will then come back to Meritus Health?
We think many will, but we want to. Our mission is create generations of physicians that are socially responsible, professionally accomplished, and community oriented. So yes, we think a lot will come back from here. 25% of our incoming class is from the state of Maryland. But the
Oh,
reality is there's so many communities like us throughout the US. We're happy they go anywhere. We have in our first class students from 22 states. And we target those who come from rural, underserved, want to be practitioners in the community.
right.
They'll still do research, they'll do everything, but they're going to be in the community taking care of patients.
What was your intention coming into the CEO position? I assume now, since you said it's going on 7 years, you didn't have any breathing room before COVID hit. Is that correct?
That's a great point. So I started 100 days before COVID hit.
Oh,
And, I was hired to essentially turn around a hospital. Meritus Medical Center, the year before I came, got a D in leapfrog patient safety. And again, there's lots of different rating systems, but
oh,
we
yeah.
wanted, as the sole provider in our county, it was our job to make a difference. Secondly, I came because Washington County, which is our primary county that we served,
Right.
160,000 people, is in the bottom quartile of health outcomes of all counties in the state of Maryland. And again, as a sole provider, as an anchor for the community, the largest employer in the community, it's our job to impact not only healthcare and health. That's why I came. Wouldn't that be fun to be part of a team that can make a difference at community health level? So that's why I came. And then along the way came COVID.
Okay, a buzzword here. What do you mean by outcomes?
So we looked at the Robert Wood Johnson health outcomes at the county level, county health rankings. And so it's anywhere from teen pregnancy, obesity, as well as some of the healthcare access metrics, as well as healthcare utilization, some of the issues around opioid use and others. So we look at health measures in addition to our typical healthcare measures.
All right. So as the new CEO, you're going to turn the organization around. Back then, what do you think you were looking to accomplish?
You know, what's great about being a community organization is wonderful people who are taking care of neighbors, right? And so it was about culture. It was how do we set the right culture so mission is what matters, and that's what we drive, and then put the processes and standard work in place to achieve that. So I did nothing revolutionary, anything that anyone else would do. Go back to the why, what we're trying to do, improve health in our region, and then get to some specific initiatives that get us there. And that's what we were starting. Then COVID hit. And to get into COVID a little bit, honestly, that was an opportunity for us to show to our community that we are here for our community. And we did it all. We started drive-through COVID testing in the back of a medical office building. We did vaccinations. We did monoclonal antibody infusion. And we did it at free access. If you could drive up, you were getting a COVID test and you were getting the results in 24 hours. And 25% of the people who did that weren't from our county.
Oh,
50% of the people who got the infusion therapy, not from our county. When we did the mass vaccinations, as a health system, a provider, we did more vaccinations in our county as a percentage than any other health system in the state of Maryland.
so during this process, what did you learn about the culture of the organization and even about your own management style?
What I learned was this: you do the right thing, you focus on quality and access, the money follows. We did not worry about money. I mean, obviously we were.
You're the first CEO I've ever talked to that didn't worry about money then.
You know, our view is, look, we're here for the community. That's our investment. So we did COVID drive-through testing for free all the time. It's like, hey, people need to know it's our job. You figure out where you're going to save the money or do something else, and it all worked out. Whether we got funding from COVID funding, grants, or we were able to cut other stuff, we made it work. Doesn't mean we made huge margins or zero, but again, we don't define ourselves by finances. Finances are the means, not the end for us.
What did you learn about your own management style?
So this is a great one. I've realized crisis in a sense, right? I love the opportunity to say, okay, we're going to set up a drive-through testing center by Friday. Let's do it. And the team and we all figured it out. And we didn't have 9 meetings and we didn't have 7 committees. We just trusted individuals to say, okay, I'll get the PPE. I'll try to figure out how to swab well. I'll try to do all the right things. We'll make plenty of mistakes and we'll improve and try it the next day. That's what I loved is when you free yourself from some of those structures, not to be that we were completely unstructured, but when you, again, take a little bit of that startup entrepreneurial culture into healthcare, It's a lot of fun.
Where was the board in this process?
So, I'm a doctor of public health. And I think this was the first time people was like, oh, now I know what public health is, right? When a pandemic comes, we think about the whole community. So I think maybe timing is everything. There was a good fit with my abilities with my team, and the board was trusting. It was early, obviously, in my tenure, but, as long as we focused on the community, they were all for it.
All right, going through your chapter, there are 3 word clauses that struck me. One was the lead council.
Mm-hmm.
Second was a healthcare equality index, then the lead dashboard. Walk us through, if health equity was the focus, why did you need a lead council and what was its charter?
Absolutely. So, one of I think the challenges with health equity is we've approached it to understand the problem, to look at the data and know we have to do something. And a lot of people get stuck in those beginning phases. Okay, Let's really try to understand. We said, let's just figure it out. We stratified some quality measures. We did some stuff to see. But the most important part is the improvement, right? It's the interventions. Yeah. So lead council at least provided us a forum to talk through those. But what we really did is apply our improvement methodology to health equity and disparities. I don't see a lot of organizations do that. Tackle it just like when you're trying to reduce central line infections or surgical. Say the same thing. I want to reduce the disparity in hemoglobin A1C scores greater than 9 for white patients versus Black African American patients. Take that as an improvement project. LEAD gave us the opportunity to have a dashboard that said, all right, here are the 5 we're working on. How are we doing every month? We have the data. And then the council will just try to provide a little accountability to that.
All right, so why was a council, let alone your council, necessary to pull this off?
I think when you have a new topic, sometimes it'll get blended with all the other things. So this separated a little bit. Secondly, we were actually, this was coming on the heels of the George Floyd death and other things. Not only was it healthcare disparities, but we were doing the other things where team members or employees felt like, hey, now we can talk about these things. Now I can have cultural events. Now I can focus on educating staff on use of pronouns, all the other things that were kind of, I think, simmering. This gave a forum to say, let's try these things. Let's do these things.
So had there not been a council, could you have achieved this?
I think it would have been harder. I think you always need some structure, some leadership, some accountability to drive it. And it's not just the council, it's the dashboards, right? I mean, we want to measure how we're progressing or not. I'm a math major, I have to admit. So metrics help to do that, right? It helps you to see, hey, we started 6 improvement projects and 5 aren't going great. 1 might be. But if we didn't have that, oftentimes in healthcare, what we do is we wait another quarter, and we have another meeting. Monthly lead council meetings with the dashboard with people focused on improvement project reporting out drives accountability.
All right, so what is the Healthcare Equality Index and how does that relate to the dashboard?
Yeah, so, and I believe you're talking about kind of like what we did in COVID in terms of looking at.
Yeah.
So, it's interesting because during COVID, it's amazing. We talked about disparities for a long time. COVID hits. And what a surprise. We still have disparities in who we were vaccinating, who was getting treatment. And it's not like it's just going to change overnight because a lot of these things have fundamental system issues. So we did an index to say, of all the vaccinations were we providing, was the percentage or the ratio of whatever demographics we use white versus non-white patients, was it the same as the population we served? And if not, then that meant we weren't getting to people who may have been non-white, may have had greater access barriers. So we use the index as a way to see, like, are we in our zip codes getting to all the people we need to?
All right, so you had goals as all part of the charter. What goals were met because of this, and what goals have yet to be met?
Yeah. So the one that we have been focusing a lot on is on diabetes care. And so at their hemoglobin A1C, we've reduced that disparity between white and non-white patients, but we still have a ways to go. But by targeting individuals in our primary care offices that may have other barriers, have other social determinants of health, having our care managers reach out to those patients and make sure that they come in for their testing, all the stuff that gets to eliminating the disparity. We've still struggled in some of our women and infants care. Our C-section rate is still disparate between patient demographics. Our breastfeeding rates are very disparate between white and non-white moms. That, and again, it's not just what happens in the hospital when you deliver, it's all the education leading up to that in the office, in the OB, to say, here's why breastfeeding is important, here's how it is as a health and as well as healthcare, and working through some of those barriers. So we still got a ways to go.
When you mention maternal health and infant health, it's, for the most part, that's the canary in the coal mine for all the indicators. Why is it so disparate in your area? And is your area any different than other municipalities that you've looked at?
I don't think it's any different than any other. I'll tell you this. I mean, it wasn't that long ago, if you think about it, 50 years ago, 60 years ago, where a Black African mom couldn't go to the same hospital as a white mom, right? I mean, I worked in my previous organization in a hospital where the person who was leading facilities and stuff was not allowed to be born in that hospital. So it's not that long ago that we're coming from this institutional systemic kind of bias, so to speak. So I think there's still a lack of trust sometimes. I think the ability to communicate and educate, peer to peer is still a challenge. And so when you put those two together, it seems like breastfeeding should, hey, try it, right? But if they don't know, if their friends didn't try this when they were in a hospital and all this stuff, it's not going to happen. So we've got to really go upstream to get that awareness, that education, and trust to get us there.
Yeah. Are you collected a lot of information on, social determinants of health? What were the follow-up actions that probably could not have come to fruition without the analytics of what those findings were? What
So this is
what were
my
the findings?
Yeah, so this is one of my favorite parts. So we do a simple social determinants of health screening of any patient that goes into primary care.
Okay.
Do you worry about putting food on the table? Is housing an issue? All that stuff. One of the ones we ask is, are you lonely?
Hmm.
And it was about 7% of the people said they were lonely of our patient population. So we tried something. Once they said that, we sent it to our care managers, our outpatient care managers. They then reached out to the person and said, do you want someone to call you once a week, once every 2 weeks for 20 minutes just to say hello? They say yes. We got a team of volunteers. I'm a volunteer. I was one of the first ones started in
Wow.
2021. And we call people. I've been doing it with two people for 4 years now. And we now have 50 volunteers and two paid staff who call about 350 people every 1 to 2 weeks. The outcome we have is we haven't seen any decrease in utilization or ER visits, but we surveyed them 4 months after being called, and 95% said they felt less lonely. Now, again, I don't call this hardcore randomized controlled trial research, but it doesn't cost a lot of money other than two staff and volunteers and us reaching out. It's not harming anybody, and they feel like it. One of my care, we call it our care caller program. The one I've been talking to, she just turned 100 years old this week. And so I went to her party at the Western Sizzlin to give her flowers and say hello. I mean, you build relationships and connections. So that to me is, how do you address the social determinant health? You figure it out and you try something. The second one I'll tell you is transportation. We
Hmm.
found transportation is a barrier. So we went all in last year, 2024 actually. We bought 9 vans, have 9 drivers, a dispatch person, and we provide 15,000 free van trips a year. Anybody in Washington County who needs an appointment, a transportation to get to a medical appointment, we provide it for free. That's another way to do it. Now, we've been fortunate to get grants and all this stuff to cover, but our view was, we're going to go all in. If I can't find $500,000, $600,000 a year as a team out of our $800 million a year budget to provide free transportation, that's on us. We should be able to figure that out every year. And we did that. The third thing I'll just throw out is food. That's obviously a
Right.
big topic. So we started a food pharmacy with an F. So last
Yeah.
year we started this. A provider at Meritus can prescribe healthy food for a patient in our electronic medical record, Epic.
What is a emeritus?
Meritus at our health system.
Oh, Meritus. Okay.
Yeah,
Yeah.
sorry. And so that goes to our care managers who call the patient and say, do you want free food for 12 weeks? And we'll give you recipes and we'll try to help you to sustain. And we now have 300 people getting free food just by visiting a doctor, being prescribed healthy food. We're not solving every social determinant of health, but our view is, if we can not only find out and then invest, we can't invest everything, that's our way to contribute to that. So I think I'll tell you, my advice is for organizations is, we talk about social determinants of health. My strategy is pick one or two or three and go all in. Pick one, go for it. Then a year or two later, pick another one, go for it. Obviously, we still work with our community partners, but this is how you try to eat away at a societal challenge.
So how many determinants are you basically acting on? Are you up to 5, 6, 7 now?
I would say three the most: loneliness, transportation, and food.
Okay.
Health literacy is a big one that we're trying to
Right.
figure out what's next. Housing, a little bit harder for us, might be easier for other health systems. So those are some of the ones on the future radar. But yeah, right now those three we're trying to really go
All right. So as a recovering healthcare consultant, I have to
at.
ask you,
Yeah.
How did you get physician buy-in, let alone buy-in from the administrative staff?
For something like it doesn't impact them as much as until they see the benefits. So for like transportation, it was like, what, you provide them free transportation? Then when they start seeing like their patients are using it and showing up and not canceling their appointments because of it,
Yeah,
it
yeah,
was a win, right? And food, they were like, wait a minute, we just give them free food? Yeah, not forever, but we give them, it's like, all right, then I'll try prescribing. And then when they see it happen, they're like, this is a great thing that we're providing.
right.
It makes, we're so they view our health orientation, our community health as a good thing, right? Because they, as you know, they're physicians. So they're dealing with the whole person, not just their
Right.
medical care. We're trying to help with the other parts so that they can focus on the medical care.
So to make this train go in the direction that you want, were there a series of incentives, financial incentives, organizational incentives that reinforced what the mandate was?
No financial incentives, just our vision, mission, bold goals, and then all the strategies and tactics to get us there. Now, we are in the state of Maryland where our hospital is under a global budget revenue.
Right,
So,
right.
our job is to keep people healthy and not have them come in the hospital. I don't make more money by having more people come in the hospital. I have a fixed revenue. So, in one sense, you could say there is a broad incentive for all of us to do these things if we believe they're going to keep people healthy, which
How
we
do you,
do. It's just hard to see sometimes.
okay, Maryland is a little bit different, the cost
A little bit
containment
different.
commission. Has that been a positive thing to work within?
For us, it has. I,
Oh,
I believe, there's positives and negatives and lots of flaws with any payment model. But the concept of getting paid to keep people out of the hospital,
yeah,
not come to the emergency room, is right on. It's nice not have to make money by having more people come to your ED, right? I want to do it by keeping them healthy. It's
yeah.
hard to do. It's hard to measure all that stuff, but it gives us, again, that big picture of why we're trying to do these things as a means to health is still the end. Finance is just helping us get us there.
Well, that's the message that I'd like to have it broadly applied, believe me. Every medical center in the country has this inherent tension between um, sustainability and strategic um, imperatives. How do you balance that at Meritus? The tension of the imperative and the tension of limited financings and sustainability.
That's a great question, and I claim to have no good answers other than, for us, you always go back to the why and the mission. This is why we exist. So for us, it doesn't mean we make 3, 4, 5% margin. We make 0 to 2, and we're fine with that. And as long as we can do that and invest in the things, I think that's who we are. So you have to decide who you are, how you want to operate. The board has to be in part of it, right?
Sure.
Most organizations would not invest $250 million in a medical school. That's not going to generate income for a long time. But that's what we believe in. We'll invest. So you got to start with the mission, stick to those goals, and then just keep executing.
So if another medical center, maybe a semi-rural like yours, are there 2 or 3 must-haves if you chart this course towards greater equity and greater community health, are there 2 or 3 must-haves from the board on down to really say, if you're serious about this and you're all in, what do you have to do?
So number one, I think, is complete alignment, right? So the board and the leader, absolutely, this is what we're going to do. Community health, whatever it is, you got to be aligned. That's number one. Number two is, I think you have to have some, in our nomenclature, bold goals, numerical goals that say we want to get to 0 harm. We want to lose 1,000,000 pounds. We want to have 0 suicides in our community. We want to be the most efficient hospital in the state of Maryland. You've got to set those out. Then you got to have the operating and the tactical to get there. Execution. I think that's the third. So much is known in healthcare. It's still execution. We're not going to invent AI, right? I think what we're going to be good at is when we figure out all the right tools of AI and how to do and all that, we want to be the best at implementing those better than anybody else, because it'll be out there as a commodity, and it's on us to figure out how do our physicians, how do our nurses, everybody use the tools appropriately. Somebody else is going to create them. Someone else is going to innovate. We're going to be the executors.
Well, I think to be realistic, there are some headwinds out there.
Yes.
especially in terms of equity and equity principles and programs. What's your optimism going forward that you're going to be able to keep on track and others who want to follow your lead? Where's your optimism going forward?
What I tell people is, and this is not to side skirt the issue in any way, but the naming, the words, people definitely have challenges with, whether you call it, we don't even want to say DEI or other things. So put that aside. At the end of the day, it's still about improving health, care, and quality for everybody. And the only way to do that is to reduce disparities in care, is to have health equity and that stuff. Now, you could call it something else, but the work still remains. And so I think as long as we stay focused on what do we have to do and why and for who, we don't have to worry about the labels. We can change the labels. We can do whatever we want, but don't change the what we're doing. And I think down at the heart, healthcare is like that, right? That is why we got into this, is to help others. And so I think it'll be there. I think it's challenging. I think some people get stuck in the naming and all that. And I would say, put it aside, focus on who you're
Yeah.
taking care of and why.
Have parts of the healthcare industry, do they have to rediscover their purpose and the why?
That's a great question. Perhaps that's a great question because I think, maybe in a conceptual basis, in today's world, many of us, and I'm not blaming anyone, define our success by size,
Yeah.
by how many lives we've covered. What if we did redefine our success by not how many hospitals you have or how many markets, but of your markets or of your hospitals, which ones have the best health outcomes in their counties? Who's
Yeah.
lowered uh, BMI scores across? I mean, that would be a different way to think about it. I think we're a ways from that, but I like your thought about how do you reframe it a little bit for people as a measure of success.
Dr. Josie, I have to say that's a note of optimism I'd like to close on. I've certainly learned a lot. I think you're on the right track, and I just wish more people would follow your lead on this.
You are
So thank
kind. I
you
work with
again.
a great team and awesome organization. Thank you.
Thank you.